Hello, everyone, and welcome back. We'll continue with intelligence gathering and need assessment, part two. All right, so the concepts that you're going to learn today risk assessment, intervention, researching, and abstracting. This is used in day to day life when you start working as a clinical dietitian, community dietitian, so on and so forth. And especially some concepts that you will learn, such as the Angelo framework. These are widely used in community nutrition area, and therefore it is important to be aware of these concepts. And I think I had also shared with you the example as to how on placement a couple of years back when these students were asked to do risk assessment, and they said that they have no idea what the supervisor is talking about, which is really embarrassing because these are basic concepts of community and public health nutrition, which you need to know, and therefore you need to develop the skills. And that's why it's good for you to understand the background theory of this as part of this lecture. And yes, these concepts do help in writing of grants and fundings. And these fundings doesn't just mean research fundings. Even as a dietitian in a hospital, you can apply for a lot of fundings to promote and to further your services that you could be offering. This could be internal funding, which is provided by the hospital as well. So yes, therefore it's important to understand and comprehend these concepts. For instance, on a grant funding, um, the risk assessment is one of the very important document that you submit. And of course, you are also doing that as part of your assignment one, ethics application and risk assessment. So yes, it is important to be aware of these concepts so you don't feel lost at work, and you feel confident as to what people are saying, you know what they are talking about. So yes, these I'll basically my aim and my intention is to orient you to the most commonly used concepts in the area of community and public health nutrition. So this prepares you well, not only for your placement, but even for your work lives. All right, so we have done step 1 to 6, and the two steps that we would be focusing on is intervention, research and strategy options, and risk assessment. All right, yes, this is just an FYI, guys. I have been mentioning a couple of times about the basic epidemiology slides, which I have, which could be useful for you for your assignment one. And as you will go further in the unit, you will see that there are a couple of epidemiological concepts. They will be useful for you for your assignment 3 as well. So what I have done that I have taken those specific slides from my epidemiology unit, and I have made a separate module in your Canvas. So you have those slides. But of course, I cannot provide all of my epidemiological material within the community public health nutrition unit. So I have just provided a few specific lecture and tutorial slides, which I feel are of use to you. But if you need any further information, then what is provided on epidemiological concepts, which would therefore support you in your assignments, so on and so forth. It would be helpful for you to get in touch with your classmates who have taken my epidemiology unit previously in the last year, second semester. Okay, but as much as possible, I have tried to provide you all of the important slides, which should be useful for your assignments. If you do not have, say, a previous background in epidemiology or research. So that is why these slides are provided to you. All right, so I just wanted to flag it to you that this is there available. Okay, so yes, so this is just a recap that in the last lecture, what we had looked at was problem analysis, and which was identifying what is the problem. So yes, before this, there was one more step, which was say community analysis and community engagement, where you're just informally trying to scope the nature of the issue. So it was, as I said, it was done at a very informal level, right? And yes, then comes the problem analysis, then comes the determinant analysis. So problem analysis is identifying what is the problem. Determinant analysis is identifying what is the cause of the problem. Then you want to identify stakeholders who may need the intervention, stakeholders who can support you in delivering the intervention, indirect stakeholders, all of those various type of stakeholders we had covered. Then we spoke about capacity building at various level, at individual level, at community level, organization level, systems level. Building meaning, in a very literal sense, is, for instance, you providing intervention to your participants, therefore you are building their capacity to follow certain health behaviors. All right, that is called capacity building. Then mandates, meaning always keeping in mind the national and international, say, health policies, advocacies, which can then align with your intervention and the type of project you want to deliver. All right, so basically, these were the steps we had covered in the last lecture on intelligence gathering and need assessment. And now we'll be moving on further. So, yes, so this is just an overview that the strategic framework for community and public health nutrition is the two most common types which are used, which would help you to plan and deliver an intervention, which I had spoken about various other theoretical models that are used at specific stages. For example, the social cognitive theory, trans theoretical model, and health belief model, so on and so forth. The two most common ones which help you to plan the overall intervention right from the entire program planning cycle, right from needs assessment till your follow-up evaluation. The most two common one are your Ottawa Carter and Charter, and your proceed model. All right. You also have many others, and one of the examples which I'll show you is, say, the public health intervention ladder. So the public health intervention ladder is, for instance, helping you to identify that which sort of intervention would be best suited for the community. It starts from the most lenient option till the most strict option. So the most lenient option is at the bottom. That's why it's a ladder. That you do not do anything, you just monitor the situation, the health issue. You are just an observer. Then the second best thing is to provide information, to increase knowledge, to increase awareness. Basically, your interventions, the classroom simulated interventions, you're functioning at this level where you are providing knowledge, information, awareness, so on and so forth. All right. Then it is about enabling choices, which would say happen when you are providing intervention for the second and third time, where your participants have now come into the gear of, okay, let us now change our dietary choices. All right. So having the knowledge, but putting the knowledge in practice are two different things. This is what it means: providing information and enabling a person to make the right choice in practice. All right, then guiding choices through changing default policies, such as, say, now Macca's also offering, say, apple slices and fruit juice options. At least it's better than, say, offering carbonated beverages. Then guiding choices through incentives. So for example, at the voluntary diabetes program, you have the pantry, which is offering free fruits and veggies. So that's positive incentive. Then you have guiding choices through disincentives. For example, the sugar sweetened beverage tax, which we have spoken about in great lengths in your lecture 2. Then restricting choices, for example, say, um, removing, say, as over here is written, removing trans fats from manufactured goods. So no trans fats allowed. Or else, yeah, so for example, if you had a say a rule such as, say, no saturated fat allowed in dairy products or something like that, which would not be right, because, for example, for under 2 children, you do need a whole milk option. But yeah, trans fat is a more logical option. All right, so then you have, say, eliminating choices. So eliminating choices is more, say, strict than restricting. So eliminating means there's a complete ban. So there is a government public health policy where you say ban, there is a big ban on something. So like, say, no sugar sweetened beverages to be sold within schools, within hospitals, so on and so forth, stuff like that. Okay, so yes, so this is called as a public health nutrition ladder. Okay, then you have uh, how would you intervene, which was even said in the earlier lecture, was you want to identify determinants. And one of the way which I identify determinants is by classifying them as modifiable, non-modifiable determinants. For example, if your topic is on, say, promoting healthy food choices to overweight and obese, say, adolescents, as it is written over here, then you would be, say, dividing your determinants as modifiable and non-modifiable. Non-modifiable, you can't do anything about it, say ethnicity and stuff like that. In modifiable determinants, you may have several, but then you may be thinking that what is something most feasible for me to do immediately. For example, if you had to do, say, a 40-minute session with school children in a real life situation in schools, you can't change all of these modifiable determinants in one intervention. So you have to pick your battles. So maybe you may start off with saying nutritional labeling. All right. So this is what I mean. So like you may have lots of modifiable interventions or say options, but you have to choose which modifiable intervention do I target on, and that depends upon many things. It could depend upon your resources, your time, availability, money, priority of the school. Maybe your need assessment shows that the school kids, they just don't understand what labeling is. They really don't know how to read labels. And maybe in the need assessment focus group, you may have found out that they are interested in at least understanding and learning what do these label mean. Would they then apply this knowledge in practice? You don't know about that, but at least they are showing interest. So maybe there could be an option of the intervention becoming sustainable, where they are more conscious and aware about their choices when they are selecting processed food items which have labels. All right. Um, then yes, levels of community and public health nutrition intervention starting from system levels. So like, global thing. For example, where you had the sugar sweetened beverage tax, which we spoke about in lecture 2. So this is like, say, a national level ban on, say, or taxing sugary beverages. All right. So yes, there was this policy document from New Zealand, which showed that after 1 year of, say, sugar tax, there was a 12% decline in sugar sweetened beverage sale. So sale is what I'm talking about. But you know how we had say looked at that video in which certain studies had shown, of course it was not in the New Zealand setting, but still, that yes, the sale of sugar sweetened beverages went down, but of alcohol increased. But also the positive note is that in other countries, you had the sale of water increase as well. Of course, then you have also the other issue of bottled water and things like that. But let's just take one step at a time. Okay. All right. So yes, as I said, we still need studies, longitudinal studies, which shows that yes, when you have sugar tax ban, this actually reduces obesity. Those studies are yet to come out, longitudinal studies, because this sugar sweetened beverage tax is something very, very recent. So those type of studies will take time. Okay, then you have community public health interventions at a community level. A community level intervention, say for example, which is done from University of Canberra, is taking students on study tour. So you have, as I had mentioned, that one of our colleagues, she takes some students to Nepal, which is an excellent experience for the students, where they are teaching basic hygiene technique, which of course directly say promotes and is positively associated with reducing malnutrition, especially undernutrition in Nepal. All right, then you have Kathy, for instance, who takes students to Tonga and Samoa as part of, say, and they do various health promotion activities over there related to nutrition. So yes, these are the type of community level interventions is what I'm talking about. The community level interventions, for instance, which I used to do in India, was going to the urban slums of Mumbai and say giving nutrition education to mothers about how they can use local ingredients and make nutritious meals for their family, which are cheap and affordable. So things like that. All right, then you have individual level intervention. Individual level intervention is all of the interventions that you are going to do in a simulated setting in a classroom, all right, where you're trying to modify, say, a individual level health behavior, meaning those people who are coming to your intervention at a particular time, all right. So those are individual level interventions. They are particularly targeted to change an individual's knowledge, attitude, awareness, practices, those things which you are doing. But of course, even dietary patterns and physical activity patterns can be changed in an intervention setting as well at an individual level. Then you have the concept of intervention research and abstracting. So basically, what this means is for example, to do your theoretical homework, which is like say doing how you do need assessment before the intervention to find out what the problem is and why is there a problem, and you do a theoretical need assessment and you have a practical thing which is focus group and stuff. Similarly, before you start say implementing an intervention, you do a theoretical homework to identify what sort of intervention will work best within this community, within this setting, for this health issue that I have identified via the need assessment. So, need assessment tells you what is the problem. For example, childhood obesity. Why is this a problem? Because these school children are consuming sugary, sweetened beverages, and they think that is cool and water is not cool. Just making up an example. All right. So, this is what your need assessment has told you. Now, you want to plan a school based intervention, which is increasing the knowledge awareness among children about say importance of drinking water and say alternative healthy beverages in comparison to sugar sweetened beverages, or particularly say carbonated drinks. All right, so you now you know this is the sort of an intervention you want to plan. But now what you have to do is, now you have to go back to the theory. As I said, everything starts first with say a theoretical overview and understanding, and then you do a practical one. All right, so just like in need assessment, you have theoretical need assessment which you are doing as assignment 1 part 1, and you have a practical side of it like doing focus groups and stuff with your participants, stakeholders. Similarly, over here you first review the literature to identify and understand what sort of say school based interventions which are targeting sugary sweetened beverages, which ones were successful, why were they successful, if they were not successful, why were they not successful, what are the take home messages which I can implement and incorporate in my population setting or in my say target group setting. All right, and that's why you create say summary tables, just like how you're creating summary tables for need assessment. Similarly, you create summary tables for say various intervention based design on your research topic. Okay. All right. So then, why is this important, guys? Why is it important first to study properly that what are the various interventions that are going on from a theoretical perspective? Why is this important? Is because you do not want to reinvent the wheel. One of the biggest reason why you do this homework. For example, in Wollondally, when we were given funding by the Southwest Sydney Local Health District, we were say asked that yes, create a diabetes prevention and management program, which is yeah, good, all right. But then first the talks were about yes, let's start say a healthy eating garden, and let's start a fresh food pantry, and let's teach them about healthy foods and stuff. But when we did a need assessment, we found out, hang on, all of this is already there in the community. There are subsidized pantries, there are walking groups, there are these community gardens. People are actually they have an understanding of what is diabetes and things like that. What they are not aware of is all of these connection between these resources. All of this is there in the community, but they do not have awareness of, oh, there is a pantry, there is a walking group, there are community gardens, stuff like that. All right, so this is what I'm saying, that our intervention was connecting people to the existing resources rather than reinventing the wheel and starting from the scratch, say building a fruit and veggie garden. That is not what they wanted. They already had community gardens and they had so many fruits and veggies to give off for free. All right. So it is about, this is why, means doing a intervention research and abstracting is important, because you do not want to reinvent the wheel. You want to do something which will actually benefit the community, and your intervention is going to be sustainable. All right, then you have risk assessment. Okay, so you are doing risk assessment again as part of your assignment 1 part 2, the risk assessment plan. So let's just briefly go over what is risk assessment in theory like. while teaching you. So what are the different types of risk? You have expressed risk. Expressed risk meaning it has clearly shown evidence that if you do this, this is a risk. For example, if you do not want the spread of COVID, what did we learn? You need to maintain a 1.5 meter distance. You need to wear a mask. You need to wash your hands, things like that. Okay, so that is a complete 100% evidence that if you do not do these things, you are very likely to get COVID. Okay, so this is expressed risk where you have clear evidence that if this is done, this will happen. Okay, so this risk is unavoidable. For example, if you want to avoid COVID, you in a COVID infested area, you cannot not say have these precautionary measures of wearing a mask, 1.5 distance. You have to do all of that. All right, then you have potential risk. Potential risk, it may be sporadic risk. For example, I'll give you this example of what which happened in India. You know how I told you about the iron folic acid supplementation program, the VIX program. So this program, which I explained to you in your week 2, which was in Afghanistan, and I told you it's also running in India. So in certain schools, they associated, children who were having, or these adolescent, say, females who were having these iron folic acid supplementation, they were actually feeling really sick after that. They used to have abdominal cramps, vomiting, diarrhea, all of that stuff. They started blaming these supplements. They're like, something is wrong with these supplements. Maybe the supplements which are supplied is of poor quality, stuff like that. They did thorough analysis of these supplements. There was nothing wrong with it. What they found out was that the school water, so the water which the school was providing for the girls to take the supplement, that was contaminated. All right. So the Streptococcus aureus contaminated drinking water. So that was the problem. The supplement was not the problem. So this is a sporadic risk. Like, you do not anticipate this to be happening, but this could happen. Like, means therefore it is important to see what are the various variables which are immediately impacting your intervention, and is there a risk around it. So yes, if you are doing a risk on supplementation trial and you are supplying all of the resources, you need to check for the water, you need to check for the food, you need to check for the utensils, all of that you're using in your intervention. Okay, then you have perceived risk. So this is a risk which is perceived by the target group, which they feel is a concern, and that's why they don't want to follow your dietary advice and health recommendations. And this is something which I had explained to you that when we had the national park in Mumbai, where you have the tribal community residing. So over there, where the NGO were telling them, oh, have eggs and things and stuff. So they were worried that eggs is a hot food and that can cause miscarriage and things. And therefore, women, even if they were deficient in vitamin A and they were undernourished, they wouldn't be having the high biological value protein eggs and things. Okay, so yes, so these are the social beliefs, cultural norms, normative norms, which can then impact your intervention, and they need to be accounted for. Okay, so now what are the various methods in assessing risk? All right, so there are multiple methods. The first one is prioritization model. So now you are prioritizing what is it that you want to do with the community. I have a tickle in my throat. This is what happens when you keep talking and talking. All right, so the prioritization model. So I'll do this with an example again rather than theoretical stuff. It doesn't make sense. Okay, so it's a numeric approach. So basically you come to a number and which helps you to decide which way to go. All right, so now I'll take the Woollendali example. Over here, for example, you have, we had funding to do, say, the Southwest Sydney Local Health District wanted us to develop a diabetes management program and a diabetes prevention program. But they had only given us funding where you can say start off with one program. And in the coming years, you can say do the other program, say management versus prevention. So our question was, do we start with the prevention program or do we start with the diabetes management program? Okay, so this is the case scenario. That is what I mean by example 1 and 2. All right, so then this is the formula. This is the formula for prioritization to identify your priority, meaning which way you should go. So A is the A, formula A. Okay, so A stands for size of the problem or the health issue. All right, bigger the problem, more marks it gets. And how do you decide whether the problem is big or not? Now, this depends upon your expert consensus, meaning it is like a Delphi method. When all experts sit together, they brainstorm, and then they decide, yes, we think this is a bigger health issue, like that. All right, so clinical management, how do we decide that? So as you can appreciate that individuals with diabetes will have clinical management of diabetes, and individual with diabetes, so 20% of the voluntary population resident were affected with diabetes, and 80% were at risk of diabetes. So in terms of the size and the scalability of the problem, individuals who are at risk of diabetes was a bigger problem. Okay, so it got a higher mark. So that is 8 out of 10. This is 5 out of 10. Okay, then comes B, which is seriousness of the problem. How serious is the problem? Okay, in terms of how do you define seriousness? In terms of urgency, economic loss, healthcare burden, psychosocial burden, involvement of the caretakers, of say healthcare workers, so on and so forth. Okay, so again, it's a range between 0 to 20. Clinical management definitely was more serious because you have secondary diabetes related complication. We know it is a big burden to the economy and the healthcare system. This has say physiological and psychosocial implications on the patient and their caretakers, so on and so forth. Okay, so more serious problem, 18 out of 20 marks. This is 12 out of 20 marks, the prevention side of things, lifestyle management. Okay, then you have C, which is effectiveness of the strategy, which is now this is again based on previous literature. Okay, and the maximum score is 20. So what previous evidence has shown, previous say clinical evidence, medical evidence, and previous scholarly literature has shown that clinical management of type 2 diabetes, if you clinically manage type 2 diabetes, say using the case conference approach, and because that is the approach which we were going to advocate within the voluntary shire, the case conference approach. Case conference approach is where you call multiple, say, experts on one field, endocrinologist, podiatrist, psychologist, dietitian, diabetes educator, and then you discuss the complex cases of type 2 diabetes, and then you give the intervention to the clinical intervention to the individuals. So that was the approach which was suggested. So yes, the clinical management using case conference approach in theory by previous literature has shown that it reduces the HbA1c by 5 percentage points, which is really good. Okay, so it got a marks of 18 out of 20. Lifestyle management based on previous literature and scholarly literature has shown to decrease HbA1c by 1 percentage point. Okay, so that received say 10 out of 20 marks. Okay, so then you have the last one, which is PEARL, which is property, economic, acceptability, resources, legality. So P meaning, do you have a intervention side? Yes, we have the intervention side voluntary to do the say lifestyle prevention intervention. We do have a community hall to do the medical intervention. We do have the GP clinics, and they are happy to lend their clinical setting room. Okay, then you have E is for economic or sustainability. Do you once you go out of the community, meaning once the funding is seized and we go out of the community from voluntarily, will the intervention, like the positive effects of the intervention keep continuing? With the case conferencing medical approach, no, because we were going to appoint an endocrinologist for the case conferencing via the research funding, which the Southwest Sydney Local Health District provided to us. But once the funding ends, the research funding ends, the endocrinologist will not be appointed, and there is no endocrinologist in Wollondally. Okay, so for any sort of expert advice, people used to go to Campbelltown. All right, so that's the closest available town or city-ish place. Okay, so no, the clinical intervention via case conferencing is not really sustainable. The lifestyle prevention intervention, will this be sustainable? Yes, because we were going to use a peer support model, meaning we were going to train peer support facilitators who are community leaders and champions, and they would be say encouraging people to maintain a healthy lifestyle and therefore to prevent diabetes. So yes, that was sustainable. And yes, it was economic because it did not require any extra funds. All right, so peer support were not paid. They were just very motivated individuals in the community who wanted to volunteer for this role. So there was no extra money involved. Acceptability, yes, both of the interventions would be culturally acceptable, socially acceptable, and demographically acceptable within the Bulundali Shire. So that was no problem. Resources, for two, do you have the resources like for the, say, the prevention side of things? Yes, because I was going to run the, say, intervention, train the peer support facilitator. So I was there as a resource. Once I train the peer support facilitators are always going to be there in Bulundali. Unless someone migrates to interstate or something. But yes, they would be there because they were retired elderly individual and who were looking forward to participate. On the other hand, for case conferencing, we needed telemedicine instruments, and this would not be sustainable because the currently the funds which were provided, we did not have enough funding to say appoint a research dietitian and buy a telemedicine instrument. Um, to start the case conferencing. So it was like an either or choice, and telemedicine was way more expensive than appointing me to do the intervention. Okay, so yes, that was not sustainable, and so that it doesn't get a mark over there. Legality, yes, everything would be ethically approved. Both the intervention were sound, say clinically, ethically, morally, scientifically, so that was no problem. So example one, you need to meet all of these, say, factors to get a 1 mark. So it is 0 or 1. So for your example two, which is the lifestyle prevention one, it gets a yes everywhere. Okay. But the clinical management, it gets a no at 2 places. So it gets a 0 mark. Now you input all of the numbers in this formula. And if you see the last one, which is your D, this one, you're multiplying this formula with D. And your D over here is 0. So at the end, the clinical management thing ends up with 0, which could have been 138, but you're multiplying with 0, so can't help it. And the prevention side of thing, it scores 66.7. So what does this mean? It means that in the first round of funding of the Voluntary Diabetes Program, we should go with the prevention side of things. And we went with the prevention side of things. And after 6 months or so, we got a second round of funding and we started the clinical side of thing. And in the clinical side of thing, that is when we started with the case conferencing, telemedicine, carbohydrate counting, say prevention, interventions, sorry, for the type 2 diabetes individual as well. Okay, so I hope this makes sense. So this is how risk prioritization is done with the formula, the say the numeric formula. Now you have the Angelo framework. Angelo framework is used very, very commonly with say in the area of obesity to identify which would be the best way to move forward. And in Angelo's framework is particularly used just as an FYI for childhood obesity. Okay, so guys, this is the Angelo framework where you have this empty grid and then you add in the information. Okay, so for example, microenvironment setting means says things which are immediately affecting childhood obesity in your population setting. For example, it could be say, you know how when I give an example where the kids thought that water is not cool and sugar sweetened beverage is cool. Okay, similarly, for example, in this what they have written is maybe the children's are viewing or perceiving healthy food as being boring and tasteless and they don't want to eat it, stuff like that. So those are the micro environmental factors. So I'm just giving you one. It's not rocket science. You can read the rest. On the other hand, the macro environmental factor in terms of socio-cultural stuff could be, say, marketing of unhealthy foods. All right. So that is a macro environmental factor where the media industry and the advertising and the food industry is involved in marketing their food products. Okay, then what you do is you develop study objectives based upon the Angelo framework grid. Okay, so you select things which you feel that are of most importance for your target group, and those are the factors you want to intervene them on. So you may select 4 of these determinants out of the, so all of these are determinants. So of these, you may select four most important one. And how do you reach to these four more important one? As I said, it is about expert consensus, the intervention team coming together and deciding this. So the first one you have is increase awareness about healthy food among school children. Second is encouraging school canteen to have healthy menu options. Third is advising government to develop healthy canteen strategies in terms of school policies, and then reducing marketing of unhealthy discretionary foods, so on and so forth. So then what do? You rate the objectives in terms of importance and changeability. Okay. So importance is ranked 1 to 5, 5 being most important. Okay, so in this bracket, all of this is importance ranking. Then you have changeability, meaning how easy it is for you to change this, to intervene this. Okay, that is again 1 to 5, 5 being the most easiest. All right, and this is the answer for this one. Okay, for changeability. Again, you reach this consensus via discussing, having thorough discussions with your project team members. Okay, and then what do you do to get a final score? You multiply importance into changeability. All right. So increasing awareness, yes, it is very important, and yes, it is quite feasible to change. School canteen, yes, it is important, but you feel awareness is more important because that is something immediately that you can start an intervention on. Okay, and then it is changeability. Yes, it is still practical to change. It is within your power, which is by contacting the school, and then, like, maybe it's a second intervention that you do. Therefore, the importance is a little bit less. Okay, so yep, second intervention, meaning, see, with any place you may do multiple intervention. You may have, say, a series of 6 to 7 intervention over a period of 6 months. What you are doing in classroom, just one intervention, that is just an example. Okay, say a eye opener for you to how the real life functions in terms of, say, interventions and program planning cycle. But in real life, one of intervention is not sufficient. You would do multiple interventions with your target population. Okay, so over here it receives a score of 15. Similarly, advising the government. Yes, it is important, but it is not really in your control. Reducing marketing, again important, but not really in your control to change at the moment, for instance, and therefore this is the score it receives. So the maximum score is for increasing awareness among school children. So school children are your stakeholders, and school canteen, meaning say intervening the canteen staff and all those stakeholders that are responsible for making decisions on what comes in the canteen for sale. Those people are your immediate stakeholders in this case. Okay, so yes, so then basically this gives you the answer that you need to plan an intervention on both of these, say, topic. These are your immediate, say, objectives for planning and designing an intervention. Okay. All right, so this is just an FYI, guys. This is just an FYI that you have other also risk management and strategy prioritization. This is called as ACE, which is assessing cost effectiveness. And you do a thorough, comprehensive table as such, again, with a lot of, say, your project team consensus on, say, strength and evidence, meaning what is the current, this is say in sort of, say, research abstracting, which I told you about. You review the current literature to see which sort of intervention has been most successful and why. Then you look at this in terms of equity. Is this something which you can apply across various ethnicity, cultural group, economic status? Acceptability, how acceptable this is in your population in terms of resource, time, energy, cultural sensitivity, labor, everything. Okay, then you have feasibility, how practical it is to do this, how sustainable this will be, and then what are the say following effects of it, positive and negative. All right, when you do this entire thing, then you come up with a common consensus that which sort of intervention will be most feasible and practical for you to promote and advocate in your situation and circumstances. So this is called as ACE. And yep, this is the last one, guys. The most common way of doing risk assessment at, say, at a small community level, individual level, is the one which you're doing for an ethics application, which is you prepare a potential risk assessment, say, template, where you are identifying the risk, you are rating the risk, and then you are also providing potential solutions as how you will be addressing the risk. Okay, and then in what time frame and who's responsible for it. All right. So guys, this is say the most practical thing which is done. ACE method and these type of numeric methods, these are most commonly done, say when you are planning something at a national level, international level. So in bigger scenarios they are done, say on a day-to-day basis where you and me will be most commonly working, we use this risk management template. Okay, but yes, if you were to work in UNICEF, WHO, something like that, then you wouldn't be surprised to see that they may be using the more, say, comprehensive methods of risk management assessment, not management, sorry, assessment and prioritization. Okay, so yep, I guess that's about it. That is your end of your intelligence gathering and need assessment. Okay, so yes, I'll sign off over here and I'll see you in the next lecture and tutorial very soon. Thank you.